The plan is to finish up this chapter today. If I do not finish it up during today's lecture, I will go ahead and create an addendum to this lecture that will be available to you by this weekend, so that you will have all of the material to study over this weekend, or if you aren't already studying it, for the upcoming exam, which you know is on Friday. And the learning paths are posted, so let's roll along here and see how far we can get. We were talking about mean arterial pressure. So this is the average rate of blood flow throughout the arterial system. And we start with our pressure that we experience at the aorta and the aortic arch, which is around 120 millimeters of mercury. But as we go down the vascular tree, you do realize that further away you get from the heart, that pressure and therefore flow will slow down, correct? Because we talked about peripheral resistance in previous lectures, but the further you go down a long tube, the slower the flow will be. And so mean arterial pressure is a number that is used to check cardiovascular health. And it's something that is done typically only in certain places where you're concerned about somebody's cardiovascular health, and that is in the CCU or ICU. So mean arterial pressure is something that actually is measured in these environments and is a very good indicator of cardiovascular integrity and physiology. It is your diastolic blood pressure plus 1/3 of your pulse pressure. And the reason we start with the diastolic blood pressure, because that is the amount of time you're in diastole versus systole is more in diastole than you are in systole. So that's why we start with the diastolic blood pressure in the creation of our mean arterial pressure. So 1/3 the pulse pressure, and so that makes the average mean arterial pressure in somebody that is hemodynamically stable around 93 millimeters of mercury. If you have a drop in blood pressure, because your cardiovascular system is compromised, then the mean arterial pressure will be lower. And also if you're having serious hypertensive crisis, the mean arterial pressure will be higher. So this is a good number to actually utilize in helping us to assess somebody in the CCU, but not somebody that's not in the coronary care unit. Also, it's average pressure of blood flow, and so having that number also is indicative that blood is flowing through the vascular tree itself. Capillary blood pressure, we are around 35 millimeters of mercury at the arterial end of a capillary bed, and then at the venous end of that capillary bed we are around 15 millimeters of mercury. I put plus there because that number does vary, but those are the numbers we're going to stick with. We're going to stick with 35 and 15. What's important too is that you actually realize as blood flows through the capillary bed, we do not have that pulsatile action. We have moved further and further and further away from the pump, and therefore we actually now have equalization. We have no more pulsatile nature to systole and diastole. And also the time spent in the capillary bed is prolonged. It sure doesn't like me, does it? So the time spent in the capillary bed is prolonged, and the reason we want to prolong our time in the capillary bed is that that is where diffusion occurs. And if you're not there long enough, you will not have adequate diffusion occurring to actually help replenish our tissues of their much needed oxygen and other ions and proteins, and also get rid of the carbon dioxide and that wastes. Interestingly, when we take a look at our notes and we're moving along the vascular tree, and now we're on the venous side of things, our venous blood pressure starts off at around 15 millimeters of mercury, because that's the venial end of the capillary bed. And strangely, we end up dropping down to about 0 millimeters of mercury right there at the right atrium. And so that's really difficult to actually figure out. Well, when you see those numbers, you think, well, blood cannot be in those vessels, or blood that's in those vessels is not flowing. And what this number tells you is that these vessels are super flabby. And so the more you put in them, then the more they stretch. And you have to realize that these vessels just don't tolerate a large amount of pressure under ordinary circumstances as blood is flowing back, because they are designed to actually just kind of collapse on you when they're empty, and then just, you can fill them up as much as you want because that's their construction itself. So then, with these numbers being very low, you realize that there is blood in them, but how are we going to get that blood actually back to the heart? And we have some important factors that help us to get the blood actually back to the heart on the venous side. And what you are using right now to get your blood back to your heart is what we call the respiratory pump. And I want you to realize that this pump is a play on words, because when we talk about pumps, like the heart, there is this big bolus of blood that actually is ejective. We actually have nothing ejecting blood here. We actually have a push-pull mechanism that's actually occurring with our respiratory pump, and it's all related to the diaphragm. When you are not inhaling, your diaphragm is relaxed. And the diaphragm is that area that's between your thoracic cavity and your abdominal pelvic cavity, correct? You guys saw that with your cats. And let me ask you, when you were working on your cats, was the diaphragm flat, or did it actually bulge up into the thoracic cavity? It bulges up into the thoracic cavity. And that's a relaxed diaphragm that occurs with exhalation. Your thoracic cavity is a closed space, yes? The abdominal pelvic cavity is a closed space. So when we take that diaphragm that's relaxed and we contract it, it flattens. And let me ask you, let's first just think about the spaces in a relaxed diaphragm situation. You have a certain volume in the thorax and you have a certain volume in the abdominal pelvic area. Now when the diaphragm contracts and flattens down, what has happened to the volume in the abdominal pelvic area? It has decreased. So therefore, what does that mean about the pressure in the abdominal pelvic area? Increased. Now let's go to the top side of the diaphragm. What have we done to the volume in the thoracic cavity? We've increased it, and therefore what have we done to the pressure in that cavity? Decreased it. You guys following me with this? So you have to realize blood flows from an area of high pressure to an area of low pressure. Are you starting to hopefully get my drift here on this? So when the abdomen is decreasing in volume, it's increasing in pressure. And remember, our veins have valves in them. And so when you start squeezing on these vessels with valves that are designed to only allow blood to flow in one direction, you start milking that blood in the direction back towards the heart. And so that's the abdominal component that we're talking about here. Now let's go up to the thoracic component, and I want you to realize, just as we were talking about, we're increasing our volume, therefore decreasing our pressure, and the blood is going to flow to the decreasing pressure area. And so this action almost is like sucking the blood into that thoracic cavity. And what structure is in our thoracic cavity? It is the heart. And so these factors aid venous return. So it's the inhalation that is going to aid venous return, correct? Because then when we exhale, things flip around. We decrease the volume in the thorax and therefore slightly increase the pressure in relationship to inhalation, correct? You guys still with me on that? So inhalation is what's bringing the blood back to the heart. That's what you are doing right now. That is what's facilitating venous return to your heart as you sit here. And then as you get up and move around, the other thing that facilitates venous return is another thing that's not a real pump. It's the muscular pump. It's your skeletal muscles. Because we have veins that are actually deep but thin and surrounded by muscle tissue. And when you contract that muscle tissue, you're going to squeeze those veins, and you're going to do the same thing to those veins that are surrounded by skeletal muscles, and it's going to milk the blood back towards the heart. And that's what the valvular system is all about. So these are two important factors that aid venous return. So remember, inhalation enhances or increases venous return and understand the mechanisms for that. And exhalation will do the opposite. Now, we have two pictures here that demonstrate this, but I want you to also understand that sometimes pictures have the wrong information with it. And so it does say inspiration increases blood flow into the thoracic veins and thoracic cavity, and expiration increases blood flow into the heart and the abdominal veins. And I don't want you to pay any attention to that. I want you to follow what I asked you to, what I described to you previously. I want you to realize inhalation increases venous return, and exhalation will therefore not increase venous return. It will be less when we exhale. Let's take a look at factors affecting blood pressure. Our notes here say cardiac output. Increasing cardiac output will actually increase your blood pressure. And that makes sense to me. If we increase heart rate, we'll increase our cardiac output as long as the stroke volume is the same. And so you're putting more fluid into the arterial system, and what will that do to the pressure in the arterial system? As you put it, it goes up. So that's an excellent way to understand increasing cardiac output. One of the things that's really nice is to get your blood pressure at rest and then check your blood pressure after you've been exercising. And that will definitely show you that you have an elevated blood pressure. And the reason that blood pressure is elevated is because you actually indeed have increased cardiac output. The other thing that happens when you exercise is what to your respiratory rate? It goes up. What does that mean to venous return? If your respiratory rate goes up, means you're inhaling more, yes? So that is a really good way to also help you with pulling blood back into the output system, into the systemic circuit. So you do a couple of things that both work together to help you to increase cardiac output and increase blood volume in the arterial tree whenever you're exercising. Peripheral resistance affecting blood pressure. Well, we know that a smaller diameter blood vessel will increase our peripheral resistance. So decrease BV is for blood vessel diameter. Increases PR, peripheral resistance. And it does this by looking at things upstream. So if your arterioles and your muscular arteries and even your precapillary sphincters all contract down, that will decrease the vessel diameter. But it's not so much that you feel it distally to this, because it will decrease flow in that area. It's because upstream, because we are not emptying, we are now therefore filling up more, and that will increase our blood pressure. So increasing peripheral resistance decreases blood vessel diameter in the important areas, and therefore you look upstream, and that means that we will have an increase in BP, in our blood pressure. Interestingly, if you double the radius of a blood vessel, that will decrease resistance 16-fold. So that means that it will be 1/16 as much as it was previously before we actually doubled our radius. Increasing blood volume should increase your blood pressure, correct? Pour more blood into the system, increase pressure, absolutely. And one way that we do this on a regular basis, but that is only a temporary elevation of blood pressure because our kidneys work so nicely for us, is if we have a nice high salt diet, correct? So we can do this by increasing salt intake. will cause an increase in water retention or even water intake. Which will give us an increase in our BP. When you're a nice healthy person, you have a temporary increase in your BP, your kidneys take over, get rid of that excess sodium, and then we have return to normal blood pressure. What's interesting, somebody has high blood pressure, they typically always recommend that you restrict your salt intake in your diet. The unfortunate side effect of that is only 10% of the population's blood pressure is really that salt sensitive. So that means 90% won't really get much of an effect of decreasing their salt intake. But you want to find out which one you are. Now, how does our body regulate our blood pressure? The easiest way to actually adjust our blood pressure is to work on arterial diameter. So remember, arterioles are the little guys right before capillary beds. We start squeezing them down, increase pressure, dilating them up, decrease pressure. That is the area where we have the biggest bang for the buck as far as adjusting our blood pressure and blood distribution. The main system that regulates our arterial diameter and also the muscular arteries diameter is our nervous system, and it is called the vasomotor center, and this area is located in our medulla oblongata. The medulla oblongata will be releasing a constant stream of impulses, and the neurotransmitter is going to be norepinephrine. So this is from the sympathetic nervous system. And one of the things about norepinephrine itself, it by itself is a potent vasoconstrictor. So we will be releasing norepinephrine on the tunica media, which is the muscular layer of our arteries and arterioles more importantly. But it is the amount of norepinephrine that we release that will be responsible for providing us a baseline of vasomotor tone. So you have a certain baseline release of norepinephrine on your blood vessels, and that is what is giving you your current blood pressure. And we will have vasoconstriction if we need to actually go ahead and have an alteration of blood pressure to occur, and that means that then we will have increased neurotransmitter release. So when we talk about vasomotor tone, we're talking about the sympathetic aspect of the nervous system in our medulla oblongata vasomotor center, responsible for taking care of our basal and any adjustments that actually occur after that. As stated here, the vasomotor fibers are sympathetic efferents, are innervating our tunica media of our arteriole. And this is important as this is what is maintaining our resting blood pressure. Let's go ahead and add this up here too. Baroreceptors, we've already talked about them a little bit. We call them pressure receptors or pressoceptors. These are all just still a very generic form of a mechanoreceptor. That's the most generic term that we actually use with those sensory receptors. Again, remember, the baroreceptors we've talked about before are located in our aorta, more specifically the aortic arch and the carotid sinus, and they'll commonly be called aortic bodies or carotid bodies. So don't be surprised if you actually see that term when you hear aortic bodies or carotid bodies. Realize we're talking about those receptors, baroreceptors in the aortic arch and the carotid sinus. Now, these guys are going to measure stretch or therefore lack of. And remember, when we increase their stretch, fill them up more, we will do what to our heart rate? Decrease our heart rate, which will do what to your blood pressure? decrease your blood pressure. So indeed, that's a part of cardiac output, which is an important thing that maintains your blood pressure itself. Chemoreceptors, also in the same area, the carotid sinus and the aortic arch, and next to the carotid bodies and aortic bodies, we actually do have some chemoreceptors. The chemicals they are designed to detect are O2 levels and CO2 levels. With CO2, I'm going to put this pH next to this because this is what they respond to. They actually respond more to pH changes than they will to anything else that I have here of these three items. O2, CO2, pH is the big thing that they will respond to. What's important here is this system, our cardiovascular system, is not as pH dependent as a regulator of what it does as our respiratory system. So this is more important with our respiratory system. It will cause changes in the respiratory system before it will cause changes in cardiovascular system, except for certain areas. And we'll talk about that in very soon. Our blood pH is, remember, supposed to be 7.4. Range is 7.35 to 7.45. If we're 7.3, we are acidotic. If we're 7.5, we're alkalotic. And the biggest player in affecting our pH under ordinary circumstances is carbon dioxide level. There's other things, because we make various metabolic acids that will affect our blood pH, but carbon dioxide plays a very big role in our blood pH. And so what you have to realize is cells constantly produce carbon dioxide, yes? Because isn't that where it comes from? It comes from our cells. So cells need oxygen, and they need to get rid of carbon dioxide. And so one of the things that's important to understand is when we hold our breath, what happens to our carbon dioxide levels? They go up, correct? Because when we hyperventilate, what happens to our carbon dioxide levels? They go down. What I want you to realize, the pH of our blood, whenever we have a respiratory component to our blood pH, it is inversely related to our carbon dioxide levels. So when I say there's an inverse relationship, when I say high carbon dioxide, I mean low pH. When I say low carbon dioxide, I mean high pH. So you have to realize that the carbon dioxide content, the more we hold our breath, the more acidotic we get, correct? And one of the things that you guys did when you did your ECG in lab is breath holding. And so you were to see if there was any real immediate effect to your ECG recording when you held your breath. And many of you did not find any real remarkable effect. And that's because this process here of breath holding doesn't impact the cardiovascular system as much as it does the respiratory system, because the longer you held your breath, the more you wanted to breathe, right? And so air hunger was the main driver for that. And so that's why you have to understand cardiovascular regulation via these chemical controls is not as well manipulated by this system. Other systems, which is actually part of the central nervous system, higher brain centers, hypothalamus, remember that's the ANS center. ANS, autonomic nervous system, means fight, flight, rest, digest, sympathetic, and parasympathetic. And medulla oblongata is under control by the hypothalamus. And so whenever there's a sympathetic increase, you will have sympathetic output to the medulla oblongata, which will also increase its output. Hormonal controls. These are short-term blood pressure modulators. They are not necessarily meant to be there for a longer term. They'll help to adjust things. The adrenal medulla hormones, remember that's norepinephrine and epinephrine, which is what we call adrenaline. Norepinephrine as I mentioned earlier, causes nice vasoconstriction, which means BP up. Epinephrine also will cause vasoconstriction. However, it will not impact the skeletal muscle blood vessels so much because whenever we release adrenaline, aren't we trying to create some sort of astronomical musculoskeletal feat? And so we'll make sure our skeletal muscles are still actually receiving adequate perfusion for that. Another hormone I want you to learn about is called angiotensin II. It's commonly seen in our older literature and exams as angiotensin, so that's just because it's easier to be lazy. So angiotensin and angiotensin II, I want you to realize, are meant to be synonymous in this course. Angiotensin II is also a very potent vasoconstrictor. It is also going to cause the release of aldosterone and antidiuretic hormone. Remember, aldosterone is a mineralocorticoid that will cause you to dump potassium, retain sodium and water, increasing intravascular volume and therefore increasing your blood pressure. So that's aldosterone. However, I will tell you that it's weak. It's a weak player in increasing your blood pressure and fluid retention. The one that is a bigger player in that is antidiuretic hormone. Whenever we release antidiuretic hormone, that means we do not create urine, which means we retain fluid, which is designed to also increase your blood pressure. So angiotensin II is a vasoconstrictor. It will cause fluid retention by causing the release of these two other hormones, aldosterone and antidiuretic hormones. So it's got a two-prong approach, doesn't it? It itself is a vasoconstrictor, and it will cause the release of other chemicals which will increase blood pressure by increasing fluid or intravascular volume. So this is going to have a direct effect on our kidneys to cause them to actually retain water. All of these volume increases also help to increase blood pressure. Atrial natriuretic peptide, ANP, can also be called a hormone because it's released by the atria into the bloodstream. So a hormone produced by atria. And it's going to impact this guy. Whenever you see Na, what's the first thing that comes to your mind? Sodium. And that's what I want you to keep as the first thing that comes to your mind. Natriuretic. Let's work through that word. Sodium uretic means sodium into the urine. A diuretic, correct, makes you pee more. Now I'm saying natriuretic, which means you will release sodium into your urine. What will that do to your blood pressure? It will decrease it, because when sodium goes into the urine, what else goes with it? Always water. So that's why it's important that a lot of times it's nice to actually know a little bit about how a word is constructed. So this will decrease blood volume and therefore decrease blood pressure. The kidneys. The kidneys are involved in actual, quite honestly, long-term regulation. So the nervous system is creating your basal blood pressure, and your kidneys are going to be working along with the nervous system for long-term regulation of your blood pressure. And the kidneys can help regulate your blood pressure directly or indirectly. And by directly, it's how much urine we make. So kidneys are directly responsible for the formation of urine, correct? And so if we make a lot of urine, that means we're losing a lot of fluid, which means that we'll have a lower blood pressure. If we aren't peeing a lot, we may be retaining fluid a lot. That means that we'll have an impact on our blood pressure. So this is very important too, because also we can control blood flow to our kidneys. And when we decrease blood flow, we will definitely decrease urine output. In the blood vessels that have the biggest impact still upon our blood pressure is decreasing arterial blood flow. So if we need to retain fluid, we can squeak down on those little arterioles in our kidneys, which will decrease blood flow to the capillary network that's responsible for helping us to make urine, and therefore we will make less urine and we will preserve our fluid in the bloodstream itself. The indirect mechanism that the kidneys also have is they are a hormone producer. This hormone is often also referred to as an enzyme because it triggers an enzyme cascade. We've talked about cascade. This will cause the formation of this, which will cause the formation of this, which will cause the formation of this, and this, and this, and the effect. So renin is the enzyme or hormone, you can call it either one, produced by the kidneys whenever there is a drop in blood pressure. The kidneys are receiving a large amount of our cardiac output. We'll go over those numbers in just a moment. But one of the reasons they receive a large amount of our cardiac output is they are monitoring our intravascular volume. And so whenever the kidneys themselves feel, not at the arterial level, at the beginning, at the muscular artery, when they feel a drop in blood flow, they will then actually activate the sympathetic nervous system to cause vasoconstriction within the organ itself, but also to cause the release of this hormone enzyme, which will then cause the formation, because that's where angiotensin II comes from. Angiotensin II comes from the kidneys releasing renin, and renin then in your bloodstream finds the precursor to angiotensin II and then cleaves it like we did with our blood clotting cascade. You guys remember we went from inactive to active. And so they'll find the inactive form of angiotensin II and activate it, which will cause vasoconstriction, which then causes the release of aldosterone and also causes the release of antidiuretic hormone. So kidneys detect drop in blood pressure, releases renin, gets the formation of angiotensin II, gets also then the formation of aldosterone or the release of aldosterone, antidiuretic hormone. All of these mechanisms are hormonal, and that's why they're referred to as indirect. Looking at the next portion of our notes, we're into blood flow. The biggest area where blood is flowing in rest-digest mode is to the digestive tract. 25% of your cardiac output goes to your gut. Then 20% is going to all of your skeletal muscle mass. Amazingly, 20% is going to your kidneys. And your kidneys, those little beans, are awfully small in comparison to all of your skeletal muscle mass. So that's another reason why they're an important regulator of our blood pressure, because they are really plugged in to get rid of waste and monitor blood pressure changes, because they will directly impact it. Interestingly, your heart only gets 5% of your cardiac output, and your brain demands at least 13% of your cardiac output. And so that brain wants 13% almost all the time, no matter what's going on with you. We'll look into that in a moment when we actually look over some very important systems and blood pressure regulation in those areas. Velocity of flow. Well, the speed of blood moving through an area. It is fastest in our aorta, slowest in the capillaries, and then will actually pick up again as we get into the veins, because we do want the blood to get back to the heart when that happens. But we want it slow in the capillaries so that we actually have nutrient exchange. So this is important. for nutrient exchange, because nutrient exchange is diffusion dependent. And so when we realize this, we also can make a statement that velocity is inversely related to total cross-sectional area. And when we actually cut across the aorta, we will get about 2.5 centimeters squared for our cross-sectional area. When we cut across all of our capillaries, amazingly, we get a cross-sectional area of 4,500 square centimeters. That's letting you know we have a heck of a lot of capillaries. You can't see them without a microscope. But if you were to cut across every single one of them and put them all together, that's the surface area that you would actually encounter. Then when we look at our vena cava, superior vena cava, inferior vena cava, we get about 8 centimeters squared cross-sectional area. So again, slowest in the area with the greatest, most cross-sectional. So velocity is inversely related to total cross-sectional area. We go faster in the smaller cross-sectional area and we go slower in the larger cross-sectional area, is what that statement is telling you. We can control the flow speed via a couple different mechanisms. Myogenically or autoregulation are really big control mechanisms in tissue beds themselves. A myogenic response is based upon stretch of BVs, stretch of the blood vessels. Large volume of blood arrival will cause vasoconstriction. And that is because they're getting too much. You know, the brain is really a big player in this too. But what happens, you guys remember we talked about skeletal muscles? When somebody pulls on a skeletal muscle, it actually, what you typically do when somebody jerks on your arm, you jerk back. So skeletal muscles have that automatic response to stretch. Smooth muscles, remember I told you they have that stress relaxation response? Well, you have to understand that stress relaxation response is something that a smooth muscle can do, and the stretch is a gradual stretch. It's not a sudden stretch. So when you actually suddenly stretch a blood vessel due to a large volume of blood, that blood vessel will go, whoo, and it will contract down. That's the myogenic response. A drop in blood flow will cause the opposite. And that is because if we suddenly get a drop in blood flow, that means we're not getting nutrients to our tissues. And so there's something wrong here. We need to vasodilate, open up so that we can improve the flow through our tissue beds in that area areas. So the organs will control the flow of blood in areas myogenically and autoregulation at the arterial bed. Control. Autoregulation is due to changes in local metabolic activity. So when I say metabolic activity, if tissues are very metabolically active, what do they need more of, and what do they make more of? They need more oxygen and they make more carbon dioxide. So metabolic activity, when things are metabolically active, I mean, just like exercising, you need more oxygen and you end up making more carbon dioxide. So autoregulation is due to changes in local metabolic activity. And so when you are not getting enough perfusion or blood flow to your area, what will happen to your carbon dioxide levels? They go. What will happen to your waste levels? Going up, yes. What will happen to your pH levels in those areas? They will go down. And so this is a response to ensure that we get adequate perfusion to our tissues at all times also. Because when they're working hard, they need additional blood flow. When they're not working so hard, they don't need additional blood flow. So autoregulation is needs-based. Increased need to flush out toxins that you create metabolically, and carbon dioxide will cause vasodilation. More than enough, everything's happy and satisfied, you will actually get a little bit of the vasoconstriction. And so that's autoregulation. I want you to understand that is different from the myogenic response. The myogenic response is suddenly we're getting a big bolus of flow that we did not ask for, and so whoop, we're going to clamp down to ensure nobody is having too high of a pressure on the capillary bed side, because high pressure in capillary beds actually tear up capillary beds. Autoregulation is actually a chemical regulatory feature. Blood flow in some areas that we would like to take a look at. Skeletal muscles. Flow will vary with activity level. That makes a lot of sense. If you're sitting around, you don't need as much blood flow as if you're up running around or walking around to the skeletal muscles, for example, in your legs. What's fascinating, and what was part of the information, at rest, only 25% of the capillary beds feeding your muscles are open at any one time. So that means only a fourth of the muscle is getting adequate perfusion. And that means 3/4 of the muscle is not. And 3/4 of the muscle that is not is starting to increase in their toxins and carbon dioxide levels, yes? And then autoregulation will come along and we'll get vasodilation in the areas with the lowest pH, the highest CO2 and highest toxin level, correct? And when you do that, the other capillary bed will close off. The one that was being nicely perfused will close off. And we have what I call, if you know anything about scuba diving, we have a buddy system. And a buddy system is if you're underwater and somebody's regulator goes out and they go, I'm out of air, can we go ahead and buddy breathe? So you'll give them your regulator, they'll breathe off of yours, and then you'll say, it's my turn now. It's my regulator and it's my turn. So then you'll take it from them, but everybody will get adequate oxygenation based on this system. So this is a very modified and highly successful mechanism for which to perfuse your skeletal muscle tissues at rest. So just 25% of the capillaries are open. And remember, the thing that is causing the vasoconstriction is norepinephrine causes vasoconstriction. So the other areas are receiving norepinephrine, but it doesn't matter how much norepinephrine they are receiving. When they get to autoregulatory needs, we will have vasodilation to get rid of the toxins that are highest in those areas. We see that also in exercise hyperemia. We will actually increase blood flow to the muscle to where no longer is it 25% that's getting perfused. We're getting great perfusion of all of the muscle tissue. And again, it's in response to local oxygen, carbon dioxide, and metabolic concentrations that hyperemia is. So what this is telling you is autoregulation overrides sympathetic controls. One of the things that you can liken this hyperemia to, hyperemia means exceedingly red, overperfused. So hyperemia means overperfused. And a very simple description of hyperemia that you may have seen or encountered yourself at some time in your life is taking a rubber band and tying it around your finger multiple times to where you have it pretty tight around your finger. And you know, distally to that rubber band, your finger is going to turn white, okay, because we've got the blood supply to our tissues pretty well constricted at that time. And you know, sometimes you forget about it, but because you got interested in other things, because you got distracted, but ultimately you will come back to that finger because it's going to start to hurt. And that's because we're having all kinds of toxins accumulating and affecting our nervous system distally. And then you'll remember to take that silly rubber band off. And what color will your finger turn? Super duper red. It will actually have an overperfusion. That's reactive hyperemia. We've got so much gunk in the tissue bed area that we will actually overperfuse that just to get these toxins out of that area. Brain. I do want to, we'll stop with the brain for today's lecture, and then I'll finish this off as a supplemental lecture. The brain is the pickiest eater in your body. It only wants glucose. It only wants a set amount of blood flow. It always wants a certain amount of oxygen, and it only wants a certain amount of carbon dioxide in its environment. So it has the most precise auto-regulatory control system in the body. And carbon dioxide, CO2, is the most important stimulus for auto-regulation, because we know when CO2 levels go up, what happens to blood pH? It's going to drop. It's an inverse relationship. And when this occurs, the brain thinks that you got a rubber band around it. And so what it will do is it will cause vasodilation to its blood vessels, because it insists that you clean out all of this carbon dioxide and any toxin buildup that's occurring around it, because it's the one that's in control of everything. And it really actually is in control of everything. And so one of the things that happens is the brain needs a very precise blood flow to it at all times. And because we know about this mechanism of high CO2 and a low pH causing vasodilation, what do you suppose a low CO2 and a high pH does to the blood vessels of the brain? Vasoconstriction. And we use that information to help us treat head trauma. When people have head trauma, what happens to the brain? Is it going to stay the same size inside that cranial vault? It's going to swell. And if they have head trauma to where they're unconscious and in a coma and are on a ventilator, what will they do to the respiratory rate on that ventilator to help keep that brain swelling down as much as they possibly can? They have increased respiratory rate, causing them to blow off carbon dioxide, which will cause the pH to go up and which will cause vasoconstriction. Because if you vasoconstrict blood vessels to an area, will you have the same amount of swelling as if you had vasodilation of the blood vessels to that area? Totally different volume expansion will occur when you actually vasoconstrict. So we'll stop there and do some clicker questions, or a clicker question.